Hello everyone, we're back with Endocrine Lecture 4. We're going to talk about the adrenal glands in this lecture. All right, let me start by going to the PowerPoint. Alrighty, so endocrine system 4, the adrenal glands. And here is a picture of the adrenal gland. As you can see, the name tells you kind of where it is. Toward renal, adrenal gland. Now we have a few different layers here on our adrenal gland. We have the capsule, the zona glomerulosa. Glomerulosa is from the word glomerulus, which really means ball of yarn. So you may have heard of the glomerulus in the kidneys. This is different here, but it's still, they felt it looked like a ball of yarn. The zona fasciculata, do you remember in the spinal cord, funiculus meant ropes. So here, don't these look like ropes, cells and ropes? So fasciculata, zona fasciculata, rope-like cells. And then zona reticulata. And after that, you have the adrenal medulla, which is neuroendocrine, a neuroendocrine part of the organ. All right. All right. Yeah. Oh, and we just said that neuroendocrine function there. Now, you want to be careful because you have the capsule up here, capsule, and here's the cortex, two different areas, capsule, cortex, medulla. Capsule, cortex, medulla. I imagine that would be more of a lab question than lecture, but I'm sure you'll see it somewhere either way. Alrighty. So what is in this adrenal gland? What are we producing in these different layers? So in our zona glomerulosa, you're going to make aldosterone. As you can see here, aldosterone. Well, they're really mineralocorticoids, but the one we really care about here is aldosterone. I'll highlight that. All right, zona fasciculata. These are the cells that they felt looked like they were in ropes. And here we're going to make glucocorticoids. Which one? What's the glucocorticoid do you think we're going to discuss the most? Cortisol. So glucocorticoids. All right. Your next group is the zona reticulatus. And this one you're going to make glucocorticoids again, but also androgenic steroids. So androgenic. The androgenic steroids could also be called gonadocorticoids. Alrighty, moving on. So here's the same picture from your textbook. All right, how do we stimulate the production of, let's say, cortisol? What's our axis here? What should we put at the top? Well, our hypothalamus, let me go to hypothalamus, right, is going to produce corticotropin releasing hormone, CRH, corticotropin releasing hormone. That is going to stimulate the production and release of adrenal corticotropic hormone from the anterior pituitary. So these are, it's right there in the word, right? Tropic. They're tropic hormones, causing the release of another hormone from another organ. All right. Cortisol, adrenocorticotropic hormone, is going to cause the production and release of cortisol from this zona fasciculata. in the adrenal cortex. Does that make sense? The tears. And you're going to have the same negative feedback. I shouldn't say same, but you're going to also have a negative feedback here. So you're going to have cortisol providing negative feedback to the anterior pituitary and the hypothalamus. Does that make sense? Same concept as before. Cortisol, negative feedback to anterior pituitary, hypothalamus. Alrighty. Alright, so we discussed that. And so what do these hormones do? Aldosterone, really fun. We're going to talk a lot about that, especially in the urinary system, but perhaps a little bit when talking about blood pressure as well. So aldosterone is going to maintain, as you see here in red, maintain concentration of extracellular sodium and potassium ions. Is that important? Yes, right? Because you want to have the right levels of sodium and potassium for muscle contraction, for nerve transmission, right? So this is really important. And also it plays a role in fluid volume. Both of these areas, it's going to be acting on the kidney on reabsorption. Do we reabsorb water? Do we reabsorb or secrete sodium or potassium? All right, blood pressure. Water retention is a big deal with blood pressure. And so the aldosterone is part of the renin-angiotensin-aldosterone system, or the RAS system. All right, and it's also going to work to maintain acid-base homeostasis. It can secrete extra hydrogen ions that are in the blood. We don't want the blood pH to get too low, because having too many hydrogen ions would decrease the blood pH. Not safe, right? So aldosterone can cause increased secretion of hydrogen ions in the kidney tubules, and that will regulate the blood pH. All right, I like this figure here a lot, where you can see sodium and chloride. You have to balance out, right? Sodium and chloride, and here's the water going back in if needed. And potassium can get excreted. Why? Why would we want to get rid of potassium? Well, think about it. Which is supposed to be higher inside the cell and outside the cell? Potassium's higher inside the cells, right? So if you have excess potassium in the blood, that's something you want to excrete and get rid of. Same thing over here, hydrogen ions. If you have too much hydrogen, if the pH is too low, the hydrogen ion concentration too high, aldosterone will cause the excretion of more hydrogen ions into the urine. All right, so what's going to cause activation of aldosterone? Let's see here. Well, the renin-angiotensin-aldosterone, the RAS system. Renin cleaves angiotensin, activates it. Angiotensin does a lot of things, including activating aldosterone. So this is kind of in response to low blood pressure. So if blood pressure is too low, that will activate aldosterone. What about potassium? If potassium is too high or too low? If potassium is too high in the blood, that will activate the aldosterone. Hydrogen ions, same thing. If those are too high in the blood, it'll activate aldosterone. Does that make sense? Because what aldosterone is doing is increasing the secretion of these. You're getting rid of these into the urine. So if it's too high in the blood, that'll activate aldosterone. Aldosterone will help get rid of those and bring you back into the homeostatic range. Alrighty. Let's go back to the PowerPoint. Alrighty. Oh, so here it's saying decreased blood pH, which is the same way of saying increased hydrogen ion, if that makes sense. If you guys remember way back to chapter 2. If that doesn't make sense, please email me, let me know, because you're gonna really wanna understand that for our respiratory tractor. So let me know if that doesn't make sense, that high hydrogen ion concentration corresponds to low blood pH. All right. So what happens if we have too much aldosterone? Well, that would throw off our potassium and hydrogen levels, right? You would have not enough in the blood. So you would have hypokalemia and hyponatremia, sodium, and hypertension. And glucocorticoids, okay, so moving on to glucocorticoids, right, from the zona fasciculata. This helps the body respond to stress. And you want to be able to respond to a stressful situation and when you think stress, think sympathetic nervous system, fight or flight, right? So what do we need for that? All right, the stress response. Well, we need energy. We need energy in order to provide ourselves, if say like flight, you need the energy to run, right? So gluconeogenesis. Glucose, new, genesis, making glucose from new sources, such as proteins and fats. So basically it works to increase blood glucose levels so you can respond by fight or flight. Any other hormones do that? We've talked about a couple already, and we'll talk about more, such as glucagon. So that's a good one to keep in mind for your hormone interaction chart. Or for the question in the guided notes about synergists, right? Or antagonists if you think of insulin. All right. What else does it do? Breakdown of proteins in skeletal muscle. Why? Why would I want to do that? Well, because I can take those proteins and use them to make glucose. So we can use those in gluconeogenesis. All right, and adipose release fatty acids, same concept, gluconeogenesis, getting more glucose to respond to the stressful situation and the stressful stimuli. All right, and what else? You know what it does? It decreases levels of certain leukocytes, so you can use it as an anti-inflammatory agent, and we do. So we talked about the control already, and how we have this negative feedback loop. So here's something interesting. What if you have too much cortisol? You would have Cushing's disease. Or what if you're taking cortisol? Well, iatrogenic Cushing's disease would be from needing to take it, say, to lower the immune response to something. And what does this cause? Moon faces, a rounded face, and a buffalo hump on the back of the neck. And so if it's excessive, you can get hyperglycemia, right? Because it works to raise blood sugar. And immune suppression, you don't want to suppress it too much because you want to be able to fight off some illnesses, right? And even osteoporosis because of absorption issues. Interestingly, here is a patient who started glucocorticoid treatment, and a few years later, how it has affected her. All right. And if there's not enough, Addison's disease. I don't know if this is in our new textbook, but it was in the old, so I stuck it in. Not on the exam. But it's interesting, so I like to throw them in. So Addison's disease is from insufficient cortisol. All right. Also, if you're talking about, let's say someone is taking, let's say someone's taking adrenal glucocorticoids, what's it going to do to corticotropin releasing hormone and adrenal corticotropin releasing hormone? It's going to inhibit those, right? So when you go off, you have to go off slowly because you have to give these time to make enough to produce cortisol. Does that make sense? Okay. All right. Androgenic steroids. So these are sex steroids that affect the reproductive organs, the gonads, and also other tissues. Adrenal cortex, it's going to synthesize these, just a little bit of them, but they're mostly produced as byproducts. So we're really going to talk about estrogen and testosterone as being with the FSH and LH. All right. So the adrenal medulla, we have chromaffin cells. It's a fun word, isn't it? Chromaffin. They're derived from the nervous tissue, because remember that's a neuroendocrine part of the organ. And epinephrine is one of the number one hormone it's going to be secreting. Remember, epinephrine is a catecholamine. If you remember back to your sympathetic, parasympathetic nervous system chapter, I think that was number 14. So these are going to mediate immediate responses to stresses. So let's say we're sitting in class and the fire alarm goes off. Maybe our epinephrine levels will go up, help us to, quickly evacuate the classroom. All right. So what does epinephrine do? It's going to increase the rate. What is the rate? The speed, right? Dun, 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 dun. And it'll go from dun, 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 dun to dun, 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 perhaps. It'll speed up the heart rate. And it'll increase the force of contraction. What does that mean? Well, imagine that I have a bag. Imagine I have a bag of water here. If I squeeze it, kind of wimpy. Some water might come out, right? But what if I squeeze it really hard? A lot of water is going to come out. So if the heart contracts harder, it's going to squeeze or force more blood out. Not squeeze. But as you can see with the bag, as you can imagine with the bag, more water comes out. So with the heart does that, more blood's coming out, increased blood supply to the body. All right, so epinephrine increases the rate, how fast, and how strong the heart's going to contract, the force. All right, it's also going to dilate the bronchioles in the lung. Now, do you feel like you're back in 141? It's going to constrict blood vessels supply in the skin. So you're going to send blood to your skeletal muscles. You're going to constrict it to the digestive organs, dilate it to the skeletal muscles, dilate the pupils, right? So you can see more. Remember that in chapter 14, it talked about if you were running away from bees in a dark forest, you want to get as much light into the eyes as possible. And decrease digestive and urinary functions. All right. So catecholamines in the bloodstream, they're going to increase the effects of the neurotransmitter epinephrine, and also cells that aren't innervated by the sympathetic nervous system. So it's going to have more of a systemic effect. The sympathetic nervous system, it's only going to activate cells that it synapses on, right? But if you can release epinephrine into the bloodstream and not just in your synapses, well, then it's going systemically and your whole body can respond. It's great. All right, here's a beautiful chart of the adrenal gland, what's produced, what it does. And, we talked about this. Sorry, I already talked about this. It's interesting though, right? It's something to think about, that and how it can inhibit the production. So if you go off of the glucocorticoids, you need to give these two a chance to slowly increase their production. We need to give the hypothalamus time to make the corticotropin releasing hormone, and same thing with the anterior pituitary and adrenocorticotropic hormone. Does that make sense? All right, so we talked about the layers in the adrenal gland, the capsule, the cortex, which consists of zona glomerulosa, zona fasciculata, zona reticulata, and then it has the medulla, not part of the cortex. And that's going to make epinephrine. See if I can write that in. You'll talk about these hormones as we go through the different chapters. So you'll become very familiar with them by the end of the course. We'll talk a lot about aldosterone in the, as you would guess, in the urinary system. Also a little bit in the heart, and epinephrine in the heart. Angiotensin we'll talk about. Angiotensin is a very fun hormone. All right, and you know what else is interesting? You can think about it, and we'll talk about it more in other chapters. If there's an issue with, say, blood pressure, where could you act to cut off or to lower it, to cut off hormones that are trying to raise blood pressure, right? You could do renin, angiotensin, maybe aldosterone. What we really do is angiotensin with ACE inhibitors. All right. So this is chapter 4. See you guys for chapter 5.